All right, welcome everyone. So tonight we're going to be discussing the efficacy as well as effectiveness of PCI or angioplasties. And we're going to take a little bit of a deeper dive into some clinical trials as well.
This is actually very interesting. When I started my medical career, um, angioplasty didn't exist, and then all this guy, this name called Grunzik, put actually catheters and balloons to people. So initially they were just like balloons without stenting. Um, he unfortunately passed away, and we usually treated it for chronic stable disease, and that was a breakthrough therapy. And then people just thought if I just fix the arteries or I repair the arteries, and life is good. I'm going to tell the answer right now is that having a balloon angioplasty for stable blocked arteries makes your chest pain better, but it doesn't prevent a heart attack or stroke or makes you live longer. I'm going to repeat that. Is if you're going for a stent for blocked arteries, these are chronic stable plaques, it will relieve chest pain, but it won't make you live longer. And in the past, people say I had this 90% blockage formation, and either the surgeon or the angioplasty, I got to you just in time. That's been changed. Now, I know the best time to have an angioplasty or a balloon to the heart or a stent to the heart is when you're having a heart attack. And so, and let's explain that a little bit more. And to me, the best situation, we're falling over that cliff, but let's get away from the cliff. And that's basically preventing the disease from happening in the first place. So we'll have 3 points today to look at. One is that, the role of angioplasty for stable angina when you're having a heart attack or the plaque's unstable. And more importantly, let's prevent it or try to delay that from happening in the first place. So take it away, guys and ladies. Let's hear what you have to say. Now, this is kind of interesting. This is actually push-ups for Canadian mental health. So February 2024, we're supposed to do 2,000 push-ups between February 1st to 2023. Amir, if you could just look up and check our website at some point in time and see if there's a place to sign up at this point in time on there or not. And so what we're going to do is that I'm going to try to do 2,000 push-ups in February, and I'm not sure I can or not, but I'll encourage you to join our team. And you just have to go to this website and register and I think the team is, what's the name of our website again, Amir?
It's drcurnewhealth.com.
So drcurnewhealth.com. So our team name is Dr. Curnew Health.com, I think. So join us and see how many push-ups and get stronger. As you know, is that we're going to lose up to 50% of muscle mass starting from our 30s to the age of 70 or so. And so I'm doing pull-ups, chin-ups, bends, weights right now to try to decrease the amount of muscle loss. I lost a lot of muscles. I think we're like that. So this is one way to get fit and have some fun about that. So yeah, next slide, please. So join us and do as many you can. There's different forms of exercise. And I think this is actually really important. On the top left hand is LDL cholesterol. I'm not sure if you can put an arrow to that over there. LDL cholesterol, just right next to it, that's Lp(a), that's LDL cholesterol here. LDL cholesterol gets into the blood vessel, and that's the start of atherosclerosis. In theory, if you have no LDL cholesterol, you don't get atherosclerosis. Now, you're born with an LDL cholesterol somewhere around 0.5 or so, and you prosper quite well. And to promote regression on a coronary angiogram, you need to keep LDL cholesterol less than 1. Next to that is Lp(a), a super killing cell that increases risk. It's a genetic factor present in about 20 to 30% of us. And it increases risk of heart disease a factor 2 to 4-fold. Below that are triglyceride-rich particles. So those are triglycerides are important. We know that diabetes and resistance is important. We know that thrombosis, and by the way, people who have diabetes have double the risk of having a heart attack or stroke if we keep going downwards. And then to our Down in the middle, we have thrombosis, blood clots. That's why we have things like aspirin and Plavix. Now, turns out that Plavix is a better blood thinner, a better antiplatelet agent compared to aspirin therapy, a little bit safer. So we're looking at that over there. Then if we start going right up the top, vascular remodeling, one of the things that we don't know a lot about is that the difference between having heart disease is not a heart disease. There's a thin layer of cell called the endothelium, the lining of blood vessels, lining of your blood vessels to your heart. And you can see some genetic factor listed there. So some people will have a thin protective blood lining called endothelium. Some people have a stronger one. And so we're learning more about that. Coming down, you can see inflammation. We know that inflammation, so basically COVID, influenza, pneumonia, rheumatoid arthritis, all cause inflammation. Being overweight causes inflammation. That all causes heart disease. And we also have the vascular tones of the vessels too as well. So we need to work on all these multiple fronts. And one of the things to improve the health of your vascular tone is to control blood pressure, for instance. And so, smoking damages your blood vessel, blood pressure damages your vessel, cholesterol causes atherosclerosis. So this is the way to prevent heart disease, is to modify all these risk factors. So you can start in February by doing our push-ups together and work on that. So next slide, please. So these are things that are important concepts that we're working hard on the prevention. Motivation is what gets you started. Habit is what keeps you going right now. So for some of us, making simple changes that you can do. So I recommend everybody, start 10 minutes every day to do something healthy. One of the things, you can start looking at a webinar, or you can start doing a few push-ups. Be healthy. Now, people don't remember what you did. People don't remember what you said. They remember how you made them feel. And one of the things that I learned from surgeons or people who do angioplasty, they always say, "I got to you just in time." Well, your heart disease starts the day you're born. Um, and let's actually rethink the process, and let's actually prevent you from having your angioplasty or your heart attack or your stroke, your dementia, and the slide before are the things that you need to look at right now, and just don't rely on just ignorance. And so let's work together on that. Next slide, please. So I spent the last 50 years of my life working on this, and please take advantage and learn. Now, Revive is a very important clinical trial. This is the trial that showed that in people who have damaged hearts and who have blocked arteries, and we thought way back when is that in the 1970s and 80s, we had a series of 3 bypass trials. We've shown that the CAS trial, the VA trial, and the European trial, these were all big trials that looked at that bypass surgery made you live longer. I'll repeat that. Back in the 70s and 80s, we had clinical trials that showed that bypass surgery made you live longer. This was actually redone with angioplasty. And the initial bypass trial showed if all your 3 arteries were blocked, the left main of the main pumping artery and a second vessel was blocked. You had lots of lack of blood supply on a stress test, and especially if you have a damaged heart, that you live longer with bypass surgery. Revive in the modern day era shows that doing an angioplasty does not make this happen. And so that's actually a change in thinking. So you either can think of the 70s or 80s, or you can think of in the 2000, and I think this came out 2021, 2022. Next slide, please. So we learn. Now, people say, do I have heart disease? Well, what you see is IVUS or ultrasound imaging, or you can see that we can do things by autopsy studies. But we've learned right now is that heart disease starts early in life. And you can see in your 20s that roughly 20% of people already have coronary heart disease. If you make it to age 50, and if you can put an arrow to that, that people above the age of 50, 85% of us by autopsy studies have blocked arteries. I'll repeat that. If you make it to age 50, you have a 85% chance of having blocked arteries. So this is a progressive disease over time, growing silently. So to me is I have blocked arteries. I'm 64 years of age, and I'm doing my best to retard the rate of progression. Um, the leading cause of death in North America and Canada right now is cancer. Heart disease is a leading cause of death worldwide, but in Canada, we've actually done a good job of treating heart disease in part. So by not smoking, controlling blood pressure, and the most important thing is cholesterol medications and not smoking and all the lifestyle changes we talk about. So if you think you're exceptional, you don't have heart disease and you're 60 years of age, well, maybe you're in a lucky 15%. Um, I'm not in that lucky 15%. I'm working very hard at prevention. So I'm doing it. I hope you do too as well. And I encourage you to go look at one of our videos. Maybe you can show that vascular prevention where we went wrong. We can maybe show that at some point in time. I really like that video. It just personalizes my story and my fight against atherosclerosis. And it's on our YouTube channel. And please subscribe. We are really pleased to look at that. And so if you go to search vascular prevention, something where we went wrong, let's see what happens. So search bar here, and voila. So it's a video we did just over a year ago. It's seen only by 254 people. I think you should look at that video, and I hope you spend some time looking at that and see what you can do to be healthier too as well. I started my cholesterol medications, my journey to heart disease too late in life. Again, it starts in your 20s, your teenage years. So, and one thing to think about is keeping your LDL cholesterol less than 1.7 over a lifetime. Remember, you're born with LDL cholesterol on average around 0.5 and you prosper. Why'd you let the bad cholesterol go higher than it needs to go? I don't know. And we need to think that. Let's get back to the slide. Thank you for sharing that. Now, this is a slide about inflammation, and you can see that if you can put that, you can see the blood vessel, and you can see that thin layer of endothelium there, and protecting that blood vessel. And all these cells are causing atherosclerosis from inflammation, but need to get LDL cholesterol in that vessel wall. In theory, if you have no LDL cholesterol, you can't get heart disease. I don't think it's that simple, but getting LDL cholesterol extremely low, less than 1 if you have blocked arteries, makes a lot of sense to me. Next slide, please. Now, this slide is called the microcirculation. So you see those big vessels, the major highways in those red color, those big vessels. And then you see the small branches called the microcirculation. We don't really have good ways of imaging them. So we do our coronary angiograms, we know the large vessels, and what you're going to learn is in a trial called Orbita 3, or Orbita, is it 2 or 3? I forget now. Was it, it showed that over half of the people after their angioplasty, their arteries were open, still had chest pains called angina. That was Orbita 2. Next slide, please. So we still have lots, well, we know a lot. And that's the start of the thing. So the start of my thinking is that it's the norm to have blocked arteries, and and it's a long-term process. And please spend a long-term approach to preventing it from getting worse. So I'm going to let the team take it away a little bit. They're going to talk about what PCI is and what's happening, or PCI, percutaneous coronary intervention, angioplasty, stenting, and things of nature are all sort of in that ballpark figure. So take it away.
Perfect. Thank you, Dr. Curnew, for those insightful and motivational words as well. So just as he mentioned, we are going to dive a little deeper into a kind of debrief of what PCI is, as well as some associated risks and outcomes that were previously highlighted as well.
I know we have some background noise. Is anybody getting rid of that background noise at all?
It might be from my end, but I'm not sure if I can fix that.
Okay. If you can't, that's okay. All right. Well, that means more people are listening. That's good. Keep telling us more.
Okay, so PCI typically stands for percutaneous coronary intervention, as was aforementioned, and it is a medical procedure that is commonly used and was used more often in the past too to treat coronary artery disease, which typically is going to occur when the blood vessels that are supplying heart muscles, such as the coronary arteries, become narrowed or blocked by a buildup of plaque. And so PCI is commonly referred to as a coronary angioplasty or stenting. And so it is a non-surgical, minimally invasive procedure that is used to treat these narrowed or blocked coronary arteries. And so in a process, this is done typically in a step-by-step manner, in which a catheter is typically inserted into the blood vessels, either in the groin or in the arm. And using a special type of X-ray called fluoroscopy, the catheter is then threaded through the blood vessels into the heart where the coronary artery is narrowed. So this would be the point of target. And so then when the tip is then in place, a balloon tip is covered with a stent, which is then inflated, and the balloon tip compresses the plaque and expands the stent. And once the plaque is compressed and the stent is then in place, the balloon is then deflated and withdrawn. And the stent remains in that position and holds the artery open. So it kind of counteracts that narrowing. And so the goal of PCI is commonly to relieve those symptoms. And some common ones that were aforementioned are things like angina or chest pain. And it does so by reducing the occlusion of the coronary artery and improving the blood supply to the heart muscle, which in turn, improves the amount of oxygen the heart muscle is receiving as well, allowing it to carry out its normal functions of contraction and relaxation, which makes you feel better overall and increases your ability to be active. Next slide, please. So just an interesting fact here is that over 900,000 PCIs are performed in the US annually. And PCI for non-acute or stable coronary artery disease is typically associated with a low rate, which is often less than 1% of serious procedural adverse events. So these includes things such as death or urgent bypass surgery. And it has a very high rate of over roughly 95% of success itself. So now that we've kind of delved a little into what PCI is, PCI does hold these significant implications in cardiology. It has a large role in the management of CAD for many patients, and its benefits are commonly reported. However, there are notable gaps in our knowledge regarding PCI. So these include things such as long-term outcomes, particularly in certain patient populations, remain an area of ongoing research. So questions about the optimal timing of PCI, as was aforementioned, we want to kind of prevent it as soon as possible. The selection of appropriate patients and the comparison of different stent types and drug-eluting coatings also persist. Additionally, the factors influencing the occurrence of restenosis, or otherwise the re-narrowing of these treated arteries, and the long-term impact on overall cardiovascular health require further investigation. So it's really important that we do address these gaps, which is what we hope to accomplish through this webinar, as well as it's important for refining treatment surgeries or treatment strategies and ensure that optimal patient outcomes are achieved. And so as research advances, a more nuanced understanding of PCI's role in the comprehensive management of CAD will emerge. And this will help guide many clinicians, not in just Canada, but around the world as well, in delivering personalized and evidence-based care. And this will be more updated evidence-based care based off of recent trials. And the ongoing exploration of these implications is discussed in this webinar, where we'll go over some trials investigating PCI, which have uncovered some important findings, specifically regarding things such as relief or efficacy of PCI, and even led us to rethink some previously widely assumed assumptions that were accepted about the procedure's effectiveness.
So I will now talk a bit about a study conducted in 2019 comparing two treatment approaches with PCI, and this was the COMPLETE trial. So the COMPLETE trial centered on individuals experiencing ST-elevated heart attacks accompanied by blockages in multiple coronary arteries, which are the vital arteries supplying blood to the heart. And the study compared two treatment strategies. One group received comprehensive treatment encompassing both the culprit and non-culprit arteries, whereas the other cohort exclusively underwent intervention on the culprit artery responsible for the heart attack. So non-culprit arteries are the ones, sorry, next slide, please. So non-culprit arteries are the ones that are not responsible for the heart attack, while culprit arteries are the ones that are responsible. And as you can see in this diagram, the culprit artery has more severe blockage affecting the flow of blood. Meanwhile, the non-culprit artery has less blockage, but may still present a risk for future cardiovascular events based on the stability of the plaque itself. Next slide. The research question they wanted to address through the study was, how does addressing non-culprit and culprit arteries through complete PCI compared to addressing only the culprit lesion in clinical outcomes? And in past studies, they were able to observe that patients had less heart issues when those extra blockages were addressed, but those studies had limitations like bias and other factors. So there was a need that was addressed for a more controlled approach with a trial, and that is kind of where the complete trial comes in, demonstrating potential benefits in treating these additional blockages. The non-culprit lesions are usually stumbled upon during primary PCI, and the non-culprit lesions are discovered incidentally and may present as stable coronary artery plaques, for which additional revascularization may not offer additional benefit. However, if they have features that are consistent with unstable plaques, which have an increased risk of future cardiovascular events, there may be a benefit to addressing them during the procedure. And so there are sort of two schools of thought towards the procedure. Some think that the blockages will be stable and treating them may not be much help, whereas others believe that the blockages could increase the risk of future heart problems, so treating them would be beneficial. And to tackle these uncertainties, the complete trial was launched. And the study aims to determine whether addressing all lesions in a complete PCI procedure, rather than just the culprit, would make a difference in outcomes for patients. So here are some of the key findings. After 3 years, the group that had complete heart vessel treatment had a 26% lower risk of either dying from cardiovascular causes or experiencing a new heart attack compared to the group that only had the culprit artery treated. And the complete treatment group also had a 32% lower risk of having new non-fatal heart attacks. And when looking at a broader set of outcomes, including procedures to relieve heart-related symptoms and other heart events, the group with complete treatment had about half the risk compared to the group with only the culprit artery treated, and that was across all outcomes in general. As can be seen in the image, the red line is a group of patients who only had the culprit artery treated, and the black line is a group of patients who received the complete procedure. And when they were followed over time, you can see that the culprit lesion only group of patients had higher outcomes overall for death, heart attacks, and needing other procedures. Next slide, please. Some additional findings was that the timing that you get the treatment doesn't really change the benefits between culprit lesion only and the complete treatment, as they were quite consistent whether they were done immediately after the heart attack or a few weeks later. And they also found that there were no significant differences in the risk of bleeding or stroke between the two groups after the procedure, which suggests that a more complete or extensive procedure does not necessarily mean higher risk for the patient undergoing the procedure. In conclusion, this trial suggests that for patients with severe heart attacks and multiple blockages, treating all the affected arteries instead of just the one causing the heart attack can significantly reduce the risk of future heart-related problems.
So let's go back to the complete trial. Just the first slide about just saying the population that was studied. Go back a little bit more. Keep going back. Go back again. Here we go. Stop here. So this took patients who came into the hospital what called ST elevation myocardial infarction and had multiple blocked arteries. So what I haven't talked a lot at this point in time. These were people that came to hospital having a heart attack where the artery was 100% blocked. ST elevation myocardial infarction means that you had a plaque that's ruptured and there's a blood clot in that artery. Now, when heart attacks were first treated in the 1950s, people were hospitalized, put to bed rest, and many would die because you had an artery that was clogged off, that the body sometimes opened on its own, but late. And then came the idea of opening arteries with blood clot dissolving agents, thrombolysis, TPA, streptokinase took place. And when I was a mere resident about 40 years ago, I was a TIMI resident. So my job when people were having a heart attack was to drop everything I did and go down and see if a patient was eligible for a very strong blood thinner called TPA. And we don't use that much anymore. And it was shown that this blood clot dissolving agent actually saved lives. It limited heart attacks. So if you opened a vessel within the first few hours of a heart attack, that's why if you think you're having a heart attack, you call 911 and probably chew 2 baby aspirin. And so that really changed everything, blood clot dissolving agents. Then angioplasty came of age, and we learned that with a balloon and a stent, that we can open arteries faster and more efficiently and safer with balloon catheters. And that's been evolved over time. So those were in people that had a heart attack called an ST elevation myocardial infarction. There was clear heart damage. There was clear blood clots in the arteries of the heart on top of blocked arteries. The question remained is that if I had other vessels that have some blockage, should we fix them or not? Now, what I just told you before, if you have stable vessels, we should leave them alone. If you have unstable vessels, so the best time to have an angioplasty is when you're having a heart attack. Now, we know that if you have one blocked artery, an unstable plaque, blood clot in that artery, you probably have multiple vessels that are prone to plaque rupture. And if you advance the slide, you can see that if you already keep advancing again, keep going again, stop here. It shows that if you just fix the one blocked artery, you leave the other vessels. And we only fix arteries that are usually over 70% blocked. If we know that if we stent arteries that are less than that, we actually cause trauma and we don't actually improve the outcome, we actually do worse. So if you have significant blockage formation, and we often know the culprit by the way the blood vessel looks, you can see clot in there, the location based on the ECG and what you see on the angiogram. So we sometimes have a good sense that we can find that culprit artery. But we also learn if you have one vulnerable plaque, you probably have 3 or 4 other vessels that are prone to plaque rupture. And that's why we often use 2 blood thinners, aspirin and clopidogrel, aspirin and prasugrel, aspirin and ticagrelor, aspirin and Brilinta. And so that tries to keep the arteries open longer. So in this circumstance, when you have multiple blockages and you're having a heart attack, we tend to fix all the arteries at this stage, or try to repair. What word is repair is a better word. We don't fix, it's a palliative procedure. So keep moving forward at this point in time. So that's in the situation where you're having a heart attack. We can advance the slides to the end of that discussion there. But for most of us, the vessels are in a stable position. We have time to think about that. And we're going to learn about the Orbita trials. Tell us more.
Great, thank you, Dr. Curnew. So yeah, now we'll look at the Orbita trials. So the Orbita 1 trial, this one looked at what happens when you are on optimal medical therapy, and then you either undergo PCI or placebo PCI. And so this trial asked in patients with severe coronary stenosis, so patients with severely narrowed or blocked coronary arteries, as well as medically treated angina, does PCI change exercise time compared to a placebo PCI? So essentially, they gave some patients like the real PCI and others a fake PCI. And so why was this trial conducted? So previous trials found that PCI significantly improves exercise time, but can we fully rely on these previous findings? Because these previous trials, they were unblinded, meaning that the patients knew if they were undergoing PCI or not. And this likely caused some degree of placebo effect because many patients often assume that PCI is beneficial, and so they may overestimate or feel a greater benefit from the PCI than is actually there. And so Orbita 1 wanted to study PCI more objectively than these previous trials. And one way they did that was by including a placebo PCI, and also they double blinded, meaning that neither the investigator nor the patient knew if they were receiving the real PCI or not. And so this made Orbita the very first blinded and placebo-controlled trial of PCI for stable angina. And so in the end, the Orbita 1 trial found no significant difference in exercise time, as well as no significant difference in angina grade, as well as angina stability and frequency, etc., when comparing those who underwent PCI against those who did not. So basically, PCI did little more than the placebo when used as an additional therapy to anti-anginal medications. And so this finding seems to kind of contradict the experience of many in the real world, where patients generally report angina relief after PCI. And so Orbita's results suggest that these real world reports may be potentially influenced by placebo effects, as I mentioned earlier, leading to kind of overestimation of the actual effects of PCI. And this is why these placebo-controlled trials are still so important today for assessing invasive procedures. And so, like I said, because PCI didn't really improve exercise time or the angina scores, Orbita 1 showed that PCI is kind of hardly beneficial when added to maximal medical therapy. And this finding also demonstrates that the relationship between stenosis and angina is not so simple or not so linear. Otherwise, PCI would be able to fix everything. And we see here that that's not the case. But Orbita isn't saying that patients should never undergo PCI for stable angina. Because Orbita 1 looked at PCI as an add-on procedure, but in 2023, a follow-up study was actually conducted to investigate how PCI fares on its own without the presence of medications, and so we'll discuss that next.
So let's just pause for a second. So you go for an angiogram, and you have a 90% blockage in one of your major arteries. You and your doctor said, "This is bad. I have blocked arteries. Let's fix it." And so they took patients, again, these is chronic stable disease. So what happens when you get chest pain, when I exert myself too much, I get this tightness in my chest. It goes away after 5 minutes. Your stress test could show some blockage formation. You go for an angiogram, you show a serious blockage in the heart. These patients gave consent to be blinded to getting, you went down to the cath lab, you had an angioplasty or you had a fake angioplasty. So you had that real or fake, but you thought you're getting an angioplasty. But you also had good background therapies, optimal medical therapy. So most people who have blocked arteries, so I don't want to take pills. Well, these pills were just as good as the angioplasty. And so we use something called beta blockers to get the resting heart rate to close to 60 beats per minute. We use forms of nitroglycerin, either sublingually or by patch. We use calcium blockers, amlodipine, Norvasc, Rapamil, diltiazem. And that constellation of those three drugs are very effective at relieving angina. So people say, well, I don't like pills. I like to say I like pills because they're just as good as that procedure. And as you point out very nicely, is that if you think you're going to get an angioplasty, you'll feel better. Now, if you just backtrack to that one slide again, with that little brain thing that people talk, go back, the mindset. This comes from a publication about people that were given a milkshake. They were told in one group of people, this is a decadent chocolate milkshake, and this was about 400 calories and or 600 calories, and people felt full after the milkshake. Or you got the same milkshake and you told was a healthy smoothie with only 160 calories and you didn't feel full. The problem is they got the exact same milkshake. And ghrelin, which is a hormone released by your brain about hunger, is influenced by what you think you got. And that's why bakeries do this very well. When you go by a bakery, you have that beautiful smell, it tastes so good. I got to get that that croissant, that bread, that whatever chocolate cheesecake they're selling at that point in time. So restaurants and bakeries do that extremely well by giving that smell that triggers your brain. And the same thing, if you have a blocked artery, you're going to say, well, fix that blocked artery. But this study shows you is your belief system is extremely important of how you're going to feel. And number two, how it's presented is important. And number three is that medications are so effective and very effective. So to me, this tells me there's no rush to do an angioplasty for chronic stable disease. And that if you have trust in your physicians and in medications, they can do a wonderful job. Tell us more. Tell us about the next Orbita trial.
Right, so Orbita 2 was conducted in 2023, and this one focused more on whether PCI relieves angina significantly more than a placebo procedure in patients who are not receiving any anti-anginal medication. So in this case, PCI was given as a monotherapy. And so they wanted to ask, are PCI interventions effective in reducing angina-related symptoms without the use of background anti-anginal medication? And so the way they did that, it was a double-blind, randomized, and placebo-controlled experiment in patients with angina. And so patients stopped all their medications, and then they were randomly assigned to a group that would either undergo PCI or a fake PCI for 12 weeks. And then the study measured their outcomes using an angina symptom score. And so basically, the higher the score, the worse their health status. And so in the end, they found that the angina symptom score was 2.9 in the PCI group compared to 5.6 in the placebo group. And so this is indicating that the placebo group had a worse health condition or health status than those who had the PCI. And the researchers from Orbita 2 explained that these results actually differed from the previously mentioned Orbita 1 trial. And this was mainly because the trials were designed to answer different questions. So for instance, the Orbita 1 trial had patients who followed guideline-directed treatment with anti-anginal medications, while PCI was an additional therapy. But then in Orbita 2, they had a new patient-focused interactive documentation of daily angina on a phone application. So it was the way they collected data was a bit different. And this minimized recall bias and also produced data with greater temporal fidelity, as well as provided an extended angina symptom database. And then both of these studies together showcase that the recommendation currently to limit PCI to patients with inadequate response to anti-anginal medications may unintentionally be focusing on the cohort with like least to gain. But these studies did not provide more information about the cause of the residual anginal symptoms that were observed, because as we mentioned, 59% of patients still actually exhibited residual symptoms.
Let's go back that slide again. So Orbita 2 is a very interesting trial. So you were taking your anti-anginal medications, you had blocked arteries, but before you went for your angioplasty, your protective anti-anginal medications were stopped. Now, we don't tend to stop your protective medications, but this trial did this. And it showed that if you don't treat it with medicines, you have more angina, and the angioplasty will make it better. but it didn't make it all go away. Over half the patients still had ongoing symptoms, despite having their major arteries opened. So what could that mean about this is that, well, first of all, we mentioned this slide about the microcirculation. There could be problems with spasm or disease in those areas. It could mean that the chest pain was not all coming from your heart. We all get different aches and pains from bone pain, arthritis, reflux, acid pain that we can misdiagnose for heart disease. Or you can still get spasms of your major vessels. So it just tells me this complement. So we have two different ways of treating your chest pain syndrome. One is medications. And if you don't want to use medications, you're dead against medications, you can go for angioplasty to relieve your symptom. And we'll show you as time goes on that it's probably not a prudent thing to do for most of us. So to me, that says that angioplasty does relieve pain. And if you think you're getting an angioplasty and you don't get one, you can still relieve your chest pain, but on a background of good medical therapy, and that there's still residual chest pain in some people and many people, over half of those patients, despite having vessels that are opened. So really elegant, and these are what we call randomized controlled trials. So it gets rid of all the biases of selection. So tell us more.
So then there was also the Courage trial, and this looked at those who took medical therapy alone versus those who had PCI as well as medical therapy. And this Courage trial, next slide, please, is part of a group of trials that looked at angioplasty and chronic coronary artery disease. So these are like the Revive trial, the Courage trial, ischemia trial, and etc. And all of these trials demonstrated that PCI doesn't prevent myocardial infarction or prolong life very effectively. And it showed that the PCI is a palliative procedure. And so risk factor modification and stopping the disease are the most important keys to your success. So about the Courage trial specifically.
Right. Go ahead. Go ahead.
Okay. So about the Courage trial specifically, they enrolled patients with ischemia and coronary artery disease, and they divided them into two groups. So if you're in the medical therapy group, you received optimal medical therapy only. And if you're in the PCI group, you received optimal medical therapy as well as PCI. And the primary outcomes that they were looking at was death from any cause, as well as non-fatal myocardial infarction. And they found that there were no significant differences between the PCI group and the medical therapy group regarding heart outcomes or death. And so essentially that shows that PCI was not very effective in reducing heart outcomes, as I mentioned.
Let's just backtrack a little bit. I'm sorry, it was my fault. I put we'll backtrack one more slide. I put this out of place over here. So the courage, you had the courage not to do an angioplasty. So these were people that had blocked arteries that were randomized, so the patients knew they had blocked arteries, and the physicians knew, and then they were randomized to medical therapy or angioplasty. And the hope is that if I have a 90% blocked artery, if I do an angioplasty, I'll prevent a heart attack or stroke and live longer. It turns out it does not. So if I have blocked arteries and they're stable plaques, a stable plaque has a thick fibrous core, has cholesterol, some degree of inflammation, but it's not rupturing at that point in time. Is like, if there's no point in putting out a fire if there's no fire in your fireplace. So we showed you in complete that if you had a fire, you had inflammation, you had blood clot, the plaques ruptured, that fixing all the vessels makes sense, because you have one blocked artery, there's probably other forest fires ready to develop, and you need to extinguish that. But if you have stable, I have this tightness in my chest, I've had these blocked arteries that's progressing over time, Courage was sort of one of the trials that was done. There was two other trials before then called MASS-2 and Barry-2D that showed basically the same thing, but Courage was a bigger trial than ischemia was sort of the mother trial of all this. This was a trial that took thousands of patients who had blocked arteries, and they were randomized to medical therapy or to angioplasty. We talked about the Revive before, and those are people that had damaged hearts with even higher risk with blocked arteries. And you have 1, 2, 3, 4, 5 randomized controlled trials that if you have stable coronary artery disease, doing an angioplasty does not prevent a heart attack or stroke. It doesn't mean you shouldn't get that procedure because we need to follow people and see how they've done. We have historical trials of bypass surgery from the 70s and 80s that showed that you have multiple blocked arteries, that you do better prolongation of life left heart attacks if you did a bypass operation on all these blocked arteries. I think the way we settle this debate right now is that back in the initial trials where we did bypass surgery to make you live longer, on the first 2 years of a trial, you actually showed more heart attacks because either you do an angioplasty or you do a bypass. There's surgical risk of stroke, having a heart attack with angioplasty or bypass surgery. And then there was a survival advantage. And then by 10 to 15 years, you lost that because the disease came back and took your life or had another heart attack. So to me, this all fits a very nice picture, is that I don't feel a big rush to do an angioplasty if I have a severe blockage in my heart, if the symptoms can be controlled. Now, we all feel comfortable when there's severe, tremendously blocked arteries, and most of us will bite the bullet and do a bypass operation. And so to me is that you're getting closer to that cliff, and to me is trying to prevent you from going over that cliff, and medications are extremely effective. Very few areas of medicine have been this well investigated. So again, Revive, Courage, Ischemia, MASS-2, and Barry-2D all demonstrate doing an angioplasty in stable vessels doesn't prevent a heart attack, doesn't prevent a stroke, and really doesn't make you live longer. I think you have very severe blockage in multiple vessels, something called left main disease, and you're having lots of symptoms, and your stress test shows lots of lack of blood supply. Then I think it's very reasonable to go for a procedure, either bypass surgery, angioplasty, mostly to relieve symptoms, and the probability of making you live longer is not as certain as one thinks about. But if you're having a heart attack, then it's 911 to the hospital, and going for bypass or angioplasty. It's kind of tricky, but that's what we do in life. So to me, if I have stable symptoms, I have no rush. All of a sudden, I've been feeling fine. I got this tightness. I'm feeling sweaty in my chest. That's something new that's happening to me. Go to the hospital, be evaluated. You need to have an ECG done. You need to get that properly evaluated. It's not the time to stay at home and take antacids. It's time to go to the hospital. Make sense? Tell us more. And again, you saw that slide before. This is what makes you live longer. It's attentive to your cholesterol, your smoking, your blood pressure, your genetic risk factors, Lp(a), your vessels, your diabetes. This is the part. It's sort of like predicting the future is, I don't know who's going to win the Super Bowl this year. I'm sad that Buffalo is out again this year. Kansas City looks strong, but my hope is that the underdog Detroit comes through right now. So building a football dynasty or prevention dynasty requires multiple components. And the thing to do is the angioplasty is good when you're having your heart attack and to relieve symptoms when we can't control things medically. But this is foundational therapy. You need to fix that foundation. And I guess the thing is, if your foundation is cracked or your basement is leaking water, pumping out the water during the angioplasty isn't going to solve the foundational problem. This is a foundational therapy. These are what you need to think about. This is what we have our few hundred videos to look at over time. And this disease starts the day you're born. And LDL cholesterol is a crucial component of blood pressure, cigarettes, and remember, every time you smoke, it's estimated to lose 5 minutes of life. So work hard on this. That's why on my diet, I'm improving on. I'm going to do my push-ups for February. I'm going to do my resistance training. I hope you do that too as well. So look at that video, vascular prevention, where we went wrong, and get some insights then. So you can start your therapy much earlier. Next slide, please. And these are we going to talk about the revascularization trials? Do we have some data to share about that?
We don't have any data in the slides, but we were hoping you could tell us a bit more about these trials and their implications.
Sure. We're going to share, we'll do some data in the future, but these were, so one of the first trials that was ever done was called the Weinberg procedure, bypass surgery. So what happened, someone took the artery coming out of your breath called the mammillary artery and just stuck it to the heart and hoped that would restore blood supply. And that initial procedure relieved angina, made people feel better. Then they did a placebo-controlled trial where they actually showed that it was all a placebo effect. By sticking an artery and just plugging it towards the heart, it doesn't improve blood supply to the heart. But these were the historic trials, the European and the CAST trial. These were the trials that showed if you had 3 blocked arteries, all 3 arteries were majorly blocked. You had the main artery called the left main and a second vessel, usually the right coronary artery. And that you can prove that you lack a lot of blood supply on a stress test, and especially if you had damage to your heart that bypass surgery made you live longer. Again, the only preventive therapies back then were aspirin and beta blockers. We didn't go for that foundational therapy. So it did relieve angina. It did in the first 2 years increase the chance of you dying or having a stroke because surgery carries degree of risk. Over a period of somewhere between, 2 to 3 years to 10 to 15 years, there was improvement of heart attacks, and there was improvement in cardiovascular events. But after about 15 years or so, that benefit was gone. The disease caught up, and the disease comes back again. So to me, bypass surgery or angioplasty is think of more of palliation, but it certainly helps if you're having a heart attack. And I'm not saying you shouldn't have these sorts of things, but if you're just going to rely on a bypass or an angioplasty, and that's all you're going to do, the disease is going to come back much quicker than you think. So that's a lesson well learned over time. Thank you. Next slide, please.
So we've looked at a lot of these trials, and so where do we go from here? And so some future directions that interventional cardiologists are looking at right now are optimizing PCI techniques. So trying to find different techniques aimed at improving exercise tolerance in stable angina patients, as well as exploring advancements in stent technologies. So one example is like bioresorbable stents to enhance long-term outcomes. They're also looking at more personalized treatment strategies. So if we can identify patient-specific factors that are influencing responses to PCI, and maybe potentially exploring the role of genetic markers or biomarkers that predict these outcomes post-PCI. And so these are all interventional strategies, but far more preferable are preventative strategies. And Dr. Curnew will discuss these in the next slide.
Again, when you think of prevention, we have to think about the category of medication. So if you have a damaged heart muscle, we have medications to try to make your heart stronger, paying attention to getting your cholesterol super low. I think part of the problem is that we calculate historically on a 10-year risk of having a heart attack or stroke, but we should think about a lifelong risk of heart disease. There's a famous doctor called Dr. Valentin Fuster, one of the smartest men I've known, and one of the people I know in prevention. I heard him talk for decades. He's now the editor of Jack of Prestigious Medical Journal. He does this yearly preventive meeting. He's been on so many boards in so many areas. He's actually worked with kids with Sesame Street characters to improve their health. And he's actually launching a clinical trial taking people with an LDL cholesterol of 1.7 starting the age of 20, and is going to treat them for 10 years of cholesterol. Now, he images plaques by ultrasound, by CT angiography. He does MRs of different things, so very experimental data. And he's going to look at the rate of progression of atherosclerosis more aggressive in their starting the age of 20 years of age, and aiming for an LDL cholesterol of 1.7 versus just standard of care. And I'm thinking is that this should be standard of care right now, and we'll do. I think we need more data, but to me, it's very clear. If you wait to 50 years of age and showing that close to 85% already have blocked arteries, we know that people in their 20s who die either in the military, like the Korean War, or from autopsy studies, over 20% of people already have blockage formation. So if you have a very positive family history, my dad had his bypass at the age of 50, meaning that there's severe blockage of all three arteries. I have blockage, 3 blockages in my arteries by non-invasive studies. I have a high LP little AA. I started therapy probably in my 40s, but in retrospect, I should have started at the age of 20 years of age or younger. And so getting your cholesterol low, we know that aspirin, clopidogrel, prasugrel, ticagrelor are very effective in preventing a heart attack if you have heart disease. The value of using aspirin if you never had a heart attack or a stroke is quite low at this point in time, because aspirin does increase the risk of bleeding by 40%. We have something called rivaroxaban, Xarelto low-dose aspirin, especially in people who have we call peripheral vascular disease, blocked arteries in their legs, would benefit from protecting the legs and other vessels, especially stroke. And so we're also noting that now Plavix is a better blood thinner than aspirin. Plavix right now in Canada is about 33 cents a day. Aspirin is pennies a day, but it looks like it's better and safer. Now, inflammation is coming up. We talked about inflammation from rheumatoid arthritis, from overweight, from COVID and other infections. We have a drug called colchicine that you can use right now, attention to other risk factors such as diabetes. And don't forget the lifestyle changes with the backbone of therapy. If you smoke, stop. If you can't stop, slow down. Right now, there's Stop on the net right now. If you Google that, you can get, if you put your email address and fill a questionnaire, you get a box of all these products here. And here's my box of products right now. So please enroll. That's a good thing right now. If you want one of our team members to help you and counsel you and support you, we'll be glad to do that. Thank you for putting that up on there. Ideal blood pressure turns out to be closer to 110, but getting blood pressure down to 120 to 130 systolic is very reasonable. And remember is that at the age of 50, 85% of us have blockage formation. So waiting for the disease to expand and get worse and just ignore that problem doesn't make sense anymore, especially when we have all these preventive strategies. Next slide, please. People say, well, you know what? I'm going to take fish oils. I'm going to take garlic. I'm going to look at plant sternols and steroids. This was a trial looking at, natural products in green versus 10 milligrams of Rovastatin and Crestor. You can see that you had close to 40% reduction in the bad LDL cholesterol. And this, what they used here is just cholesterol changes. You can see the other stuff didn't work very well. So to me, I would use that works. And when it comes to fish oils over the counter, they're full of impurities, and it looks like pure EPA is what is necessary, and Vasipa is a pharmaceutical agent that very effective, but unfortunately quite costly, under $10, just under $10 a day. We can talk about that, especially if you have high triglycerides. And so taking over the counter things, and people say how bad statins are. I don't, and Amir, if you can just Google the statin debate video, I think that's something people should look at right now. Again, if you go to our YouTube channel, the statin debate, that's something we did. We done that a little while ago, and it basically tells us is that if you believe statins are harmful to you, then they're harmful to you. If you Google statin and soreness, you get about 3 million hits saying how bad they are, how they want to give you all these vitamins and other cocktails that don't really work. I just want to show you the science behind that. There's one trial called Samson that took patients who had terrible pain from cholesterol medications, were given real pill, no pill, or placebo, and it showed if you're taking a fake pill, you're just, having fake pills. 99 out of 10 soreness episodes were just the act of taking a pill. So if you want to take these things over the counter, it's not going to work. We had a patient that basically what she did is she went on Amazon, bought some blind capsules and put some artificial sweeteners in some and real cholesterol pills on the other. And her husband took the medication. He felt terrible. Then she changed it and he still felt terrible. And she said, honey, you're an idiot. She says that you're taking no medications, fake medications, and you're complaining of soreness. He was a smart guy. He loves his wife, and he also realized he made a mistake. The power of suggestion. So, I'm just amazed how we're just influenced by our environment. Yes, we all make mistakes. We all learn, but use as much science. And and we can go back to the slide presentation. So that's another one. I encourage you to take a look at this over here. So, the supplements I take is basically, I don't know, once a month or so, I take a multivitamin for good luck. But I try to eat lots of fruits and vegetables. I try to eat as many plants as I can, as many beans as I can, as much exercise. And one of the things I've is worked hard at improving my sleep and started to do my push-ups as well as my aerobic activity. Hope you can think about that too as well. And I take the highest dose of 2 cholesterol medications at this stage, and it's not enough to stop my disease at this point in time. So please learn, be attentive. Some people can get away with everything, but when you see a disease that's present in 85% of people after the age of 50, this disease is a major problem. It's a sneaky disease. It grows silently for many, many decades. But there's a lot you can do about it. Next slide, please. You can certainly go for angioplasty. This is a meta-analysis. Look at 600,000 plus patients, 123 randomized controlled trial that shows for every 10 millimeters lowering a systolic blood pressure. So I go from a systolic blood pressure from 140 down to 130, or from 120 down to 110. But basically if you can aim for a blood pressure 120 over 80, you decrease for a 10 millimeters reduction of blood pressure, you get a 20% reduction in cardiovascular disease, similar reduction in heart attacks, a 27% reduction in stroke, a 28% reduction in stroke, and just over a 10% reduction in mortality. This is big. Every time you smoke, unfortunately, you will lose 5 minutes of life. And lifestyle changes can certainly lower blood pressure on average about 5 millimeters of mercury per lifestyle changes. Each medication gives you about 10 millimeters of lowering. It's like building a hockey franchise or a football dynasty, is that you need multiple components, and look at the power of blood pressure. So if you don't have a blood pressure machine, get one. If you want to borrow one of ours, we'll be glad to loan one. And if you can just show us about on our YouTube channel and just put the word high blood pressure, we'll show you how to measure your blood pressure. And we have a short video that's all that long, from a 3 to 10 minute video. We have one on the DASH dietary approaching to stopping high blood pressure, keeping track of your blood pressure. You can just keep showing us multiple, keep going down. We have lots of videos to look at this in this area here. So learn about managing your blood pressure. And if you want to say that blood pressure is elevated in the doctor's office, you're under treating yourself. You deserve more. You deserve to know what your blood pressure under ideal circumstances are. I know if I did my blood pressure during this webinar, it will be quite elevated. And I've done that before, giving this presentation. My blood pressure has been 180 over 110. But if I measure my blood pressure relaxed in the proper way at home, my blood pressure is around 120 over 80. So, and I've also worn a 24-hour blood pressure monitor. You can decide whether or not that's something you want to look at. It's important to know your blood pressure, not just at the doctor's office. We know that some people call reverse hypertension. The blood pressure is good at the doctor's, only high at home. We know that white coat hypertension, the elevation just in the doctor's office. I don't wear a white coat anymore, but still I bring up blood pressure. I get that. And that's an intermediate risk. So these are the things you can look at. Next slide, please. So blood pressure is an important component in this therapy. And I love this slide. Take a picture of that and go back and stare at that. It's quite impressive what you can do. You know, if you just imagine your blood pressure is 170, bring it down to 140, you can actually multiply by that by 3, that factor. So hypertension is what we call a silent killer, and especially it's a major killer for strokes. And unfortunately, one of the reasons I was delayed today, we started later, is that one of our patients just had a bleed inside his head. He had a hemorrhagic stroke, and his blood pressure is all over the place. We had to deal with that. He was just out of the hospital. We're going to bring him to clinic tomorrow. And that's why I'm always late, because if you have a problem, I will find a way to fit you in. I promise never to be on time, but I will promise to do the best I can for as many of you as I can. So, and I like to be available to people who need me at that moment in time. I hope you understand that. Next slide, please. So the best way to not need me is to control your risk factors, and we can work together. Do we have any more slides to show?
No, I think that's it.
Okay. So, so let's just go back to the first slide of the day, angioplasty. This has been a long discussion. So, you know, the belief was that angioplasty is all that I need. I can fix arteries and I'm going to be good. The answer is not that simple. We learned that if you think you're having a heart attack, what I would do is call 911 and two baby aspirins, make sure I have all my pills, and get to the Hamilton General Hospital if I live in the Hamilton area. I would be at a center that does angioplasty. You need to be evaluated quickly and efficiently. Waiting times are very long, but if you're having a heart attack, someone's going to do an ECG, take a quick history. And if the ECG shows that you're having an ST elevation infarction, you're going to be off having an angiogram at that point in time. You'll become a courage patient. I'm sorry, a complete patient. And what we'll try to do is fix all the blocked arteries that are severely blocked at this point in time. On the other 10, if I get chest pains that occurs mostly with activity, goes away with rest. It's not a pain doctor. It's a tightness in my chest that comes on with activity lasting between 30 seconds and 10 minutes. That's classic angina. That means you probably have blocked arteries. We're going to evaluate you by doing things like we'll do probably an ECG to start off with. We'll do a stress test to see how far you can exercise and how severe those blockages might be. We'll probably do an echocardiogram to make sure there's been no heart damage. Then we're going to do the most important thing is if you can show that slide with all the risk factor modification. That's the slide. That's the foundational therapies. I wish I know if your arteries are quite thick and have protective barriers, some of those vascular remodeling components. I'm going to keep your blood pressure closer to 120 over 80. We're going to work on your cholesterol. I know it's hard to stop smoking. Every time you smoke, it's estimated you lose 5 minutes of life. Remember, if you smoke, 60% of people will die from a smoking-related illness. I know it's not easy. And what I was going to try to show you is my my kite surfing enterprise. I don't think we have that one there ready for you, but basically before the pandemic, that was my 5th year trying to kite surfing. This year I went back to Aruba, tried to do some kite surfing. I did I did 5 3-hour lessons. I got up from 1 to 4 seconds. I can fall a lot, and I made some bad mistakes, but I have great coaches and teachers, and I'm making slow progress. So, the war on atherosclerosis and the war, anything you do, just keep fighting at it, keep working at that. And I also want to thank the people at SOSA, the Gliding Club, who I will be at 200 flights. I'm still not ready to pilot a plane, but I'm getting better. And it comes to prevention. Let's just get better and to keep working at it. And don't be so hard on yourself for being successful, but just keep working on it and listen to the people who know a lot about the disease to give you the best advice. Today, I saw a person that we showed that he had blocked arteries. He had a calcium score 330, and he has a cholesterol in the 6 range. And he says, "Doctor, I'm not going to take any cholesterol medications. I appreciate all you've done, but at least I did the best I could to show to him that he has blocked arteries. I do worry about him. The door is always open. Encourage him to become a plant-based eater. He does enjoy fish and too much meat, and he does exercise and things of nature. I hope he makes some changes. Today I saw someone who unfortunately just got out of hospital and had a stroke, bleed inside their heads. I see every day multiple people with heart disease. We're on a mission to work on weight and risk factor modification. So take advantage. And we can decide together and go back to that initial slide about angioplasty. People feel very relieved to be in the CATS lab. I'm not as relieved as you are. I know if you have stable disease in the first 2 years after an angioplasty or so, your heart attack risk is probably higher than you think. Angioplasty does damage the vessels. If you have very severe and all your arteries are very blocked, you have left main disease, then I think we make a strong argument for bypass surgery. But we have time. And we know that after angioplasty, if remember Orbita 2, these people had disease and 59% of people still had chest pain. And we need to sort out sometimes the cause of chest pain. So it's a long story, but there's so much you can do. I hope this makes sense to everybody, and I'd like to explain that to you more. I would look at this video, pause and look, and put this into perspective. I want to encourage you to make some habits. So February is going to be push-up month. I'm not saying you should do 2,000 push-ups in 23 days or 21 days in February, but do a couple here and there. I'm not sure how many I'm going to do, but I'm going to keep working at it. And to me, I need to do this in a group environment. So I thank the people from Dundas Physio and the group I'm working with. We meet between 6 a.m. and 7 a.m. on Mondays and Wednesdays. And what a great group! And I encourage you to find it. And I thank my squash group for playing with me. And I know I'm getting older and not as fast, but I'm still working. And I thank all these young minds that are taking over the world right now. And I just like to see you as healthy as you can for as long as you can. I guess the analogy, we're walking towards that cliff. If we can keep ourselves from falling over the cliff, that's a good thing. And I think we can. And I hope you learned a lot today. I thank the team for everybody presenting right now. And Mir, I'll give you the last word. What's your thoughts?
Yeah, so it sounds like if we were to simplify this all down, the best time to get an angioplasty is when you're having a heart attack, which of course, if you're having the symptoms of, you should call 911. And like always, it seems like the best medicine is prevention, preventing all those risk factors we saw 2 slides ahead. And yeah, it comes back down to what we usually say, which is the best treatment is preventing it from ever happening.
So one thing about prevention I failed to mention is that vaccines, people are very polarized. We have a good randomized controlled trial. Getting the flu shot every year prevents heart attacks and mortality. There was a trial that was done way before the pandemic that took people coming to hospital for an angioplasty during flu season on 3 consecutive years. They were randomized to getting the flu shot or not getting the flu shot, just a placebo to that, and it showed that by getting a flu shot, you decrease influenza severity. And sometimes the vaccine works extremely well. Sometimes it's not, depending on yourself and also the variant out there of influenza. But it decreases the chance of a heart attack. We now learn that having pneumonia, being hospitalized, puts stress on your heart. There's a higher incidence of heart attacks in the first number of weeks after that, having that pneumonia shot. I'm sorry, I think I have pneumonia, excuse me. And that's why Prevnar vaccines are important, other shots are important. People who have attack of shingles, which is a disabling symptom. I had my two Shingrix to protect my vessels. We know that RSV's out there. We know that COVID now likes to be an atherosclerotic plaques. And one thing we don't know yet, what I'm fearful, is that having COVID may damage your blood vessels. It does damage your blood vessels, and then it may accelerate, blocked arteries. And I fearful for that. So I'm 64 at this stage, so I'm getting a flu shot I'm getting the COVID shot every 6 months at this point in time. There'll be other generations of COVID vaccines. I'm glad that the virus is not as strong as it was before. But I still worry that, multiple episodes of COVID injure vessels in your heart. So there's so many ways of thinking about prevention. So a famous Chinese proverb goes that a good doctor makes a good diagnosis and treats the disease. A better doctor prevents the disease. So a better patient prevents his or her own disease. So take part and see what's best for yourself. So I hope this is helpful. I want to wish everybody a great night. Thank the entire team for this presentation. And please take a look and create some new habits every day. Thank you so much, everyone.